first of all, lent us his Apple computer that saved the day. And as I mentioned, was once a research fellow here with the PHRI, and now is at University of Toronto as a professor. And his topic today is learning from counting debts. Prabhat, welcome.
Thanks very much. Thank you. My congratulations to Salim and the PHRI Symposium for really a remarkable 20 years of progress, and I'm delighted you've talked about what can be done in terms of the future. So I'm going to start with my conclusions, which are as follows. First, counting debts and describing causes is essential to the kind of remarkable progress that you saw Richard Pito demonstrate, but also thinking about the future. And I'll illustrate this by showing you about 4 quick examples, starting with things that kill perhaps tens of thousands or perhaps 100,000, going up to things that kill 1 million, to things that kill, as Richard outlined, several millions. And also touch upon risk factors, particularly those relevant for vascular disease, that is a focus of this esteemed institution research. And again, I'll start with things that are smaller and more uncertain, and conclude by more evidence on contemporary hazards of tobacco smoking in India and elsewhere. Well, why count the dead? Well, it's a very simple reason. Most of the deaths that occur in the world in low and middle income countries, particularly low income countries, occur at home without medical attention. And therefore the causes of death are not known. Only 3% of the world's kids that died in 2010 had a proper death certificate, a WHO death certificate. So in the absence of this information, you need alternative solutions. And an alternative solution was proposed 140 years ago by the Sanitary Commissioner of the Government of India, which I'll let you read, which basically says, for sanitary purposes, it is indispensable to know the small area mortality and to apply the preventable causes and the remedies. That's effectively the description of the Indian million death study, the major study that I've been doing for the last 15 or so years. And what does this involve? Well, we work with the Indian government and the Registrar General, and we take a random sample of homes drawn from each of the preceding censuses, what's called a sample registration system. And in the deaths, in the homes that have a death in the last 6 months, a team, well, there's about 900 of them, go visit and get standard questions plus a local half-page narrative about the circumstances of death. And that we convert to electronic records, and we've got 2 of 400 doctors coding online to assign a cause of these deaths with all sorts of quality control. And it enables us to study all diseases, work within the Registrar General and the government apparatus, which is not easy. I've lost most of my hair working with the Indian government, but it does yield sustainable results, and it's done cheaply. And so far, we're up to about 800,000 deaths studied. I'll show you some results on something like 600,000 deaths so far. And it will continue. The Indian government has now institutionalized this, and it's moving forward. What we've done is to take the lessons from the Million Death Study and form a statistical alliance for vital events, which is expanding these solutions to Ethiopia, Mozambique, and elsewhere. So, one of the first questions to any epidemiologist is, well, how valid is this system where you're relying basically on careful interviews with the house? Well, the key conclusion is that it gives you reliable estimates, reliable cause of death information in young life and in middle age, but it is not as reliable in old age. But that's aligns with the public health priorities, which is, as Richard outlined, avoidance of premature mortality. And I could show you lots on the validity or how good is the system, but I'll just show you one simple slide, which is we did a random experiment where we send these non-medical staff to go and ask the house what they thought the person, or interview the house about the causes of death. And then 4 weeks later, we sent 1 of 4 doctors out to those same areas, and they re-interviewed the same household. And then we looked at what was the concordance. Broadly, doctors and lay staff were getting the same results. Okay, so you don't get too sleepy in the afternoon. Now let's have a little quiz. So now here's a map of Indian mortality risk using the same metric as Richard proposed, premature or risk of death before age 70. And this shows in red, risk going from 0.5% risk of death before 70 up to the very dark red is 1%. Anybody guess what this disease is? Snakebite death. So remarkably, in India, there's been since 2000 something like 1.2 million snakebite deaths, about 58,000 a year. So that's not the biggest cause of death. We'll come to bigger ones, but it's interesting nonetheless. And you can simply by understanding the distribution show that half occur in monsoon months, half at low altitude, 7% in 8 states. And the risk is about 1 in 250, but in some places higher. In some places it's a lifetime risk of about 1 in 100. And then from it, more crudely, we can estimate how many bites occur a year. So that causes a few tens of thousands of deaths. What causes perhaps 200,000 deaths and has been underestimated is malaria deaths. And malaria is normally associated with killing children, but not with adults. But we showed in a paper initially in 2012, but updated more recently to that there's a U-shaped pattern that you see malaria deaths not just occurring in children, but in adults. And over time, with the various waves of the neonatal, or various waves of the million death study, the death rates in young children have fallen by half, but the U-shaped pattern exists. Now this is important because malaria is not just a disease that you can treat, you can actually cure it. And this is now spurred eventually, about 10 years after the paper, we started working on the paper, the interest, including by the Gates Foundation, to try to understand to the extent to which malaria is actually killing adults. And this is work that Alan Gelband has been leading with us. So Richard talked about avoidance of premature mortality, including looking at under 5 children. And the Million Death Study has been able to document what have been the successes, and mostly they are successes in India in child mortality. And these are summarized here. Neonatal mortality over about a 15-year period has fallen remarkably from infectious causes. 1 to 59-month mortality is also showing remarkable improvements, particularly also from infectious causes. But it's not all good news, because you see in the first month of life, there have been substantial reductions in birth asphyxia, birth trauma, and neonatal infections, which respond basically to increasing hospital access. But there's actually been an increase in prematurity and low birth weight. Much of this is low birth weight in term infants. But there is variation. You see that increase in rural areas in the poorer states of India, but not in the richer states or the urban areas. So these are avoidable factors that can be identified. And if we go over to Sierra Leone, where we've extended the work, this is some very recent evidence that shows, again, in the first month of life, and including stillbirths, that in a small country like Sierra Leone, there is a large percentage of avoidable deaths and a remarkably large number of stillbirth deaths, which previously was underestimated or unknown. Looking at 1 to 59 months, you see the dominance of malaria in particular and other infectious causes. So this will give the Sierra Leone government very much a blueprint, a GPS for improving their own health, much as the Indian government has with the Million Death Study. So let me turn to now vascular disease, because this is of particular interest to this audience. Well, the somewhat surprising news in India is that the risk of vascular disease mortality in middle age, I define it about the same as Richard, 30 to 69. I very much hope you go to 30 to 69 versus 35 to 69. It aligns with the UN and the WHO totals. The risk has actually been increasing from, in men, 10% to 13%, women 5 to 7. Stroke is going down modestly. And that's just shown schematically here. In 2000, India, US, UK had reasonably comparable standardized mortality rates from ischemic heart disease at all ages, but that's diverged. And it's the same with stroke. The stroke shows a threefold higher standardized death rate in India versus in UK or the US. But remarkably, there's quite a lot of variation. Prabhat mentioned the variation in ischemic heart disease, or in this high in Punjab and in the south, but we saw an unexpected variation in stroke that you see in particular in the northeast states, which are home to about 1/6 of the population, account for about 1/3 of the stroke death rates. And interestingly, in these high burden states from stroke, there actually have been increases in rural areas, and for ischemic heart disease nationally, the greater increase has been in rural areas, not in urban. Again, unexpected, and it might well be related to access to treatment, the things that Prabhat mentioned. So turning quickly to risk factors, these again Richard covered, and what I'd like to do is to start with some of the emerging ones and show you some new evidence, which is difficult epidemiologically to get right, and then turn to smoking, which is still one of the most important causes of premature mortality. So let's start with basically low body mass index, which has been identified as a particularly important risk factor in India. So Dr. Gajalakshmi's work in India showed that unlike in the West, where there's a linear relationship with higher cardiac mortality with higher BMI, you can see that curve here. Every 10 units higher BMI roughly doubles your risk of mortality in middle age from cardiac disease. But in India, the curve is flat. So there's basically two possible things going on. One is, despite higher blood pressure in those with higher BMI, there are some protective factors of being obese. But more plausibly, it is that the relationship doesn't hold because there's more harmful factors at lower BMI that offset the effects of low blood pressure. So low BMI is a very interesting phenomenon to study in India. And remarkably, about 1/4 of Indian adults are defined as having a BMI of below 18.5. And this is greater in the illiterate population than the illiterate, both for men and women. So we sought to explore, well, is there a link to what is also a unique Indian phenomenon of lacto-vegetarian diet? So we studied this by looking at lifelong lacto-vegetarianism, which is the common pattern. And this just shows the distribution. Green is the lacto-vegetarians, mostly in the Northeast, and the purple is the non-lacto-vegetarians, which are in the, mostly in the coastal areas. And the way we did this is to take this into account, the difficulty of studying this kind of epidemiology, is we looked at cases and controls from the same sampling unit, meaning there's about 8,000 randomly selected areas, small areas. So we took the cases and controls from the same areas and adjusted for all the usual things, including individual level smoking. And to our surprise, there was a small excess of mortality among men who were typically lifelong lacto-vegetarians, and a slightly greater excess in women. But the most notable excess was in wives. Now, what's going on here? Well, in fact, I asked my mother, and she said, don't be an idiot, who eats last in the Indian household in the rural areas? It's the wives. And when we looked at the phenomenon, in fact, there's an independent study that documents that men eating first is an independent risk factor for women being underweight. So what this points to in the tricky area of dietary epidemiology is that lacto-vegetarian diet is mostly posing to a deficiency diet that is perhaps deficient in calories, perhaps deficient in protein. Some of the findings that came out of Salim's PURE study. Now this needs further corroboration and further research to try to understand better. Prabhat mentioned air pollution, and I know Dr. Bauer is going to talk about this, but let me just show what we have been able to attempt, again, in a very difficult area of epidemiology to estimate. So most of you have seen this, the world's hotspots in terms of satellite-based particulate matter exposure are very much India and China. Now these measurements have gotten better over time. The satellite measurements are crude, but they're tested with ground-based measurements, and over time, these measurements have substantially improved. But what has been less certain is the degree to which that exposure increases the risk of cause-specific mortality. And you see from a variety of estimates, these startling numbers that are reported in the media of how many people are killed. Today's, or this week's issue of The Economist and the last week, all about air pollution consequences. So we start to study this by looking at the Million Death Study data. So these are in, as mentioned, about 8,000 small areas. So we link them to the satellite data, and then we did basically a spatial model where we're comparing the deaths from particular conditions, ischemic heart disease, stroke, respiratory disease, and to injury controls. Now that has problems if you use injury controls, but we tried different types of controls, and it seemed reasonably stable. And what we found is that for every 10 unit increase in particulate matter, this is the standard metric in the world, and we're using a broader age range of 15 to 69 here, that there was a small excess, 12% excess from chronic respiratory disease. But once you take into account the fact that the diseases and the exposure cluster, they occur in the same areas. Once you take into account that spatial clustering, that becomes a 2% excess. And similarly for heart attack, there was a 7% excess, but it became 3% once you take into account the clustering. Stroke, now you have to, I think all stroke epidemiology in India really should be looking at differently at high burden and low burden areas. And here, there was a surprising association, again a modest one, but a surprising and consistent association in the high burden states, but not in the low burden states. And when you do the things that you want to look at, like dose response, again, look at the one for cardiac disease. If you don't take into account clustering, there's perhaps an increasing risk with higher levels of exposure, but once you take into account the clustering, there really isn't much. So what does this mean? Well, these are really debatable numbers. And the problem is a simple one. If 99% of the population of India are exposed to what WHO calls unsafe levels, then even a risk, a 2% excess risk might be important. But our estimates suggest, first of all, incredible variation in the risks. Let's say for ischemic heart disease, it could be perhaps 33% if you use our upper risk in terms of the percentage due, because nearly everyone is exposed, or it could be 0. And now in contrast, the global burden of disease and the related GEM results with more certainty seem to suggest, well, it's actually a big cause of death among adults from heart disease, but I think we're less certain. So in practical terms, in Delhi, which is considered one of the most polluted cities, the estimate has been, well, perhaps there's, based on the GBD numbers, 6,500 deaths from heart attack a year. Our numbers would suggest maybe actually smaller, the medium estimate of perhaps around 2,500. It's still big, but quite uncertain. My personal view is that this uncertainty should not preclude action, because we know very much the effects of ambient air pollution on respiratory morbidity for children. That is enough to actually do action. But we need more certainty if we're going to make the claims of how many people are actually killed by exposure. Let me turn to tobacco and Richard covered some of this already about the growing numbers of deaths worldwide. And remarkably, the 21st century hazards of smoking were really reliably documented only recently. Many of us were at the Richard Dahl Symposium in 2012, where we traded notes from around the world in terms of what the contemporary hazards. And there's this remarkably consistent loss of a decade of life in now typical smokers versus non-smokers. So this is Richard Dahl's and Richard Pito's last study, the British doctor, the last reported British doctor study showing a decade of life. This is Million Women study. These are our results from the US, also showing a decade of life. Japanese atomic bomb survivors and Indian men who smoke cigarettes, to which I will return, also lose a decade of life. And this is how Brian Williams from NBC summarized our results.
And good news and bad news on the smoking front. From the New England Journal of Medicine, they state flat out, smokers lose at least 1 decade of life expectancy over non-smokers on average. The encouraging news here is quitting before 40 reduces the smoking-related death risk by 90% compared to continuing on as a smoker.
That's Richard Pito's career in 22 seconds. So let's look at US women, where now, because they've been smoking seriously like men, they're dying like men, and you can quantify the hazards. And the proposition here is a simple one. What's the probability of living till age 80? You can't live forever, but living till age 80 in reasonably good health is a reasonable one. And you see the remarkable divergence in US women who smoke versus those that don't. About 70% of non-smoking women will reach age 80, whereas about half of that will if they are a smoker. Richard already showed this, so I'll just skip this time. So let me turn to the Indian tobacco patterns. Indian tobacco patterns are different because men start smoking, it's mostly men that smoke. They start smoking in life and they later, and they smoke fewer than they do in the West. But despite that, we've shown that men who smoke BDs, which is the small local cigarettes, I'm sorry, that's Bides, it's a typo, it's not Joe Biden. It's, men who smoke BDs lose 6 years of life. The few women who smoke BDs lose 8 years of life, and men who smoke cigarettes lose 10 years. This is more contemporary evidence showing that from 2004 to 14, there has been a substantial decline in rural and urban men in BD smoking. Women still aren't taking up smoking. That's good news in large numbers. And there has been a decline, but slower one in cigarettes. Now, the biggest decline actually has been in heavy BD cigarettes, or heavy BD use, and less so in cigarettes. So this enables us to study what has happened in the last 10 years. And these are the results of overall mortality, showing a modest increase despite a falling prevalence, in the modest increase in the relative is despite a prevalence, but it varies by disease. In particular, respiratory disease has shown an increase, and cardiovascular disease has shown an increase, now about twofold risk. And if you look at this separately for ischemic heart disease, it is, as would be expected, greater and rising than it has been for stroke. And the concern in India, despite improvements in tobacco control, has been, what if Indian men start smoking cigarettes as heavily as has occurred in the West? This is what the tobacco companies would like. And here you see a remarkably steep increase with a threefold relative risk for those men who smoked more than 10 cigarettes per day. Okay, I'll skip this in the interest of time. Now, because the hazards of smoking are so big, so are the benefits of quitting. And the results here from a variety of studies, including the Million Women study, suggest that if you quit by age 40, you avoid about 90% of the continuing risk of smoking. Yet cessation remains uncommon in many parts of India and China. And as Richard mentioned, the best way to deal with this is really to have a large increase in tax. And this is just something that we've been working on, looking at the Canadian story. And here you see a remarkable decrease in smoking cigarettes per adults per day in Canada, going from about 5 down to about 1 or 1.5 over a time period, despite the effects of smuggling. This is commonly cited as an obstacle to higher taxes, but this was an organized tobacco industry event, and the government survived it, and the only consequence really was an excess of deaths because of the excess consumption that smuggling brought directly, but also because it scared the finance ministers to lower the prices, it raised consumption. So we estimate that in Canada, several tens of thousands of excess deaths have occurred because of the tobacco industry stunt. Okay, I'm out of time, so I'm going to skip all these other things and show you my conclusions, which are threefold. I will apologize because I gave you a lot of numbers. The criticism of epidemiologists is that we're just number crunchers like accountants. That's not fair. Accountants have more personality. This is our website. If almost all of our publications are available there. And don't buy our books, just go to our website. Thank you.